Is my voice clear?
Yes, ma'am. Perfect.
Okay. So thank you everyone for joining us. Many of you were with us for other courses in palliative care, palliative medicine that we conducted online, and some of you have already done your training from other institutions. Welcome you all for this cause. We are all here for one cause to integrate palliative care into undergraduate medical education. I'm so glad that many of you are showing interest to do and take this forward. We'll start with a quick round of introduction, a little bit about yourself and your background in palliative care so far, and how you're connected to palliative care and why you are here for this program. And then we'll have a short talk from Dr. Rajagopal on why we are doing this program, why Palliamedia is taking this initiative, and what is the vision behind this program. And we'll hear from Dr. Kadambari about the principles of integration in medical education. That is one term that we use very commonly. To understand that in a little bit in depth, we'll have a session on integration in education. So that is about today's session. You know that you are all divided into small groups. Get to know to each other. When you introduce, just understand who is your team member, because for the coming 3 or 4 days, you will have group activities which you have to plan with your team members. So please get in touch with your team members and understand who they are and where they are from, so that you can have fruitful sessions in the coming days. Thank you so much once again, and we'll start with the introduction. Shripriya, can you call out the names on the screen that you can see?
Yes, ma'am. Just a minute. The first name I can see is Dr. Sanjeev Dave. Screen. You are muted, sir.
Muted, sir. Can you unmute and talk, sir?
I am Professor Dr. Sanjeev Dave, HOD in Department of Community Medicine. I have joined this palliative medicine course. I have not done it earlier. Previously, I was enrolled, but due to my previous engagements with the department and other institutional work, I could not complete it. So I thought it would be a good opportunity to see this type of palliative course. Okay. Thank you very much.
Thank you, Dr. Sanjeev. Welcome. Next, it is Dr. Pamela.
Yeah, I'm Dr. Pamela Jairaj. I'm a radiation oncologist from Christian Medical College, Ludhiana. I am involved in doing palliative care in my institution, and I belong to subgroup 3. Thank you.
Warm welcome, Dr. Pamela. Moving on, may I request Dr. Shweta R to introduce.
Good afternoon, everyone. I am Dr. Shweta. I am a professor in community medicine in Sri Siddhartha Medical College, Tumkur. So I participated in the previous sessions. So I will be very happy to be part of this also. Thank you.
Warm welcome, Dr. Shweta. Dr. Neelam? Dr. Neelam Sharma?
Good afternoon, everyone. I'm Dr. Neelam. I am assistant professor in Department of Anesthesiology in GMC Haldwani. And I have done the palliative course earlier, FCPM 22. And so now I'm joining this part 3. And now I belong to the group 3. And I'm very much interested in palliative care medicine. So that's why I want to join this course. Specifically, in our region, we have a lot of cases of chronic illnesses and cancer patients who require palliative care. So I will looking forward for this session. And
Dr. Neelam, which department did you say you are from?
Sir, I am from anesthesia. Department of Anesthesiology.
Okay. Yes. Thanks.
Welcome, Dr. Neelam. Moving on, may I request Dr. Vicky Bakshi for self-introduction, please.
Good afternoon, everyone. My name is Dr. Vicky Bakshi. I'm assistant professor in respiratory medicine in Veer Chand Singh Gadwali Institute in Srinagar, Uttarakhand. So I being a pulmonologist, I have major role in this ICU setting also. And there we see a lot of patients which are sick and that they need palliative care. So earlier I had been nominated by my institute to go into this FCPM program. So slowly I developed interest also in this subject. So here I am now doing this FCP program. So I hope so I get to learn from this program also. Thank you. Thank you, everyone.
Warm welcome, Dr. Vicky Bakshi. Now I request Dr. Navish for self-introduction.
Good afternoon, everyone. My name is Dr. Navish David. I'm assistant professor in Department of Community Medicine. I'm medical officer in charge of Gurbachan Memorial Hospital, which is a rural health training center in the Department of Community Medicine. I'm the medical officer in charge practicing primary care as well as palliative care in my center.
Welcome, Doctor. Dr. Hagi Sonia, I'm extremely sorry if I'm pronouncing the names wrong. So sorry for that. Dr. Sonia.
Okay, you're pronouncing it very okay. I'm Dr. Hagi Sonia. Basically, I'm radiation oncologist, but I'm also looking after pain and palliative unit at Tertiary Cancer Center that is in Arunachal, Naharlagun. So it is attached to TRIMS. That is our sole medical college, which is there in the Arunachal Pradesh. So we have this, every day we have OPDs for pain and palliative from Monday to Saturday. So basically I'm looking after radiation patient as well as the pain and palliative unit. Thank you so much.
Thank you, Doctor. Welcome to the prestigious program. Moving on, Dr. Sangeeta Chaudhary, we request you to kindly introduce yourself.
I am Dr. Sangeeta Chaudhary from ESI Hospital at Calcutta. We don't have any palliative medicine branch at present. We are just, we will be starting it after this course probably. I'm actually in medicine. I'm medicine in charge at one of the ESI hospitals, Kamarati at Kolkata. Thank you.
Thank you, Dr. Sangeeta. Dr. Mohit, would you be kind enough to introduce yourself to the batch? Sir, you are muted.
Okay. Hello, good afternoon, everyone. Myself, Dr. Mohit Saini. I am assistant professor in onco anesthesiology in Sri Guru Nanak Institute of Medical Sciences, Dehradun. Basically, we run here palliative care OPD Monday to Saturday every day, and we're planning to open a ward for a palliative care. So I'm here to. I already completed the foundation course of palliative care and certificate course of teaching. That's from the Indian Society of Palliative Care Physicians from AIIMS Delhi. So that's why I'm here to learn more about the palliative care. Thank you.
Thank you, Dr. Mohit, and welcome. Now I request Dr. Saswati Mukherjee.
Hello.
Yes, ma'am, you're audible.
Yes, I'm Dr. Shashwati Mukherjee. I'm also from ESI Institute of Pain Management, Kolkata. I have done my pain degree from ESI Institute only, and I have completed my degree certificate from for palliative care from IAPC, Indian Association of Palliative Care. So now we are going to open a unit in our hospital too. For this, we are in this program. Thank you.
Thank you, Dr. Saswati. Welcome to the program, and we hope that this program paves the way to opening the center in your organization soon. Moving on, Dr. Pankaj Sinhai, warm welcome. We would request you to kindly.
Hello, everyone. I'm Dr. Pankaj Singhai. I am working in Sri Aurobindo Institute of Medical Science in Indore, Madhya Pradesh. I look after the palliative care unit here. And thank you, everyone. Thank you, Pallium India, for giving this opportunity. I'm looking forward to learning here. Thank you.
Thank you, Dr. Pankaj. Dr. Neha Khatur, it's your turn. We would request you to kindly introduce yourself.
Hello everyone, I'm Dr. Neha Kathur. I'm currently in SGRR Institute and Medical College in Dehradun. We are running a pain and palliative care clinic regularly in our institute. I'm with Dr. Mohit. And we are also seeing the ITD patients for the palliative care, and we are planning to open a total palliative ward and hospice care. Hello.
Yes, I think we lost you for a couple of seconds.
Okay. So I'm saying we are planning for our palliative ward and a hospice care in our institute.
Great to know that, Dr. Neha. Welcome to the program. Moving on, Dr. Rosia. You're muted.
Hello, my name is Dr. Rosia. I'm from Tertiary Cancer Center, TRIMS, Nahalagan, Arunachal Pradesh. I just completed my 3-month course, palliative course under Dr. Hage Sonia and Tashi ma'am. Looking forward for this wonderful experience. Thank you.
Welcome, Dr. Rosia. We also expect that this becomes a wonderful experience for every one of us. Moving on, I now request Dr. Dipankar to kindly introduce himself. If you could keep the cameras on. Thank you.
Yeah, hello. Good afternoon, everybody. Myself, Dr. Dipankar Dakwa. I am from Guwahati, Assam. I am working as a palliative care physician at State Cancer Institute, Guwahati. And I am working under Assam Cancer Care Foundation, which was established in 2017 in Assam. And we are in a tertiary cancer center here in Guwahati itself. Thank you.
Thank you, Dr. Dipankar. Welcome to the program.
Thank
Moving
you.
on now, as Rajagopal sir would say, we see some black boxes, black screens over there, but still I am going to call out the names. Dr. Hem Chandrabhat. Sir, you are muted if you are trying to talk. In best interest of time, maybe we will move on to the next part.
Hello, good afternoon,
Yes,
everyone. Myself, Dr. Hemchand Bhatt, Assistant Professor in Department of Anesthesiology, GMC Haldwani. So I have a keen interest in palliative care. That's why I have joined this call. Thank you.
Thank you, Dr. Hem. Now it is the turn of, I would not make the mistake of calling out wrong names again. Dr. Alte. Extremely sorry, I am unable to pronounce your first name correctly.
That is exactly right. That's how my non-Mizo friends call me. I am Dr. Mapui, and I am working as an assistant professor in the Department of Pathology. So I'm a pathologist working in the only medical college in Mizoram. So I have been nominated by my institution to attend this program, and I look forward to learning a lot from this program, and I belong to group number 5. Thank you.
Warm welcome, Dr. Alte, and we wish to see that your hopes get fulfilled. Now I request Dr. Sumit Kumar Singh. Sir. Dr. Sumit.
Hello. Myself, Dr. Sumit Kumar Singh, Assistant Professor, Communication from BC Nagar Medical College. Hello.
Sorry, your voice was breaking. We could hear that you are from community medicine, but we didn't hear.
Hello. Hello.
Yes, sir. Yes, sir. Far better now.
Myself, Dr. Assistant Professor in Medical College.
So we didn't hear you again. Can you type it in the chat and send so that we can understand?
So there is a network problem here. So I can.
Yes, sir. We would highly appreciate that if you could type your introduction and send it in the chat box. Meanwhile, moving on, I would request Dr. Bharat Nag to kindly introduce himself to this cohort. Dr. Bharat? You're muted, sir. Okay.
Good afternoon, all. I am Dr. Bharat Nag, working as assistant professor in community medicine department in Sri Siddhartha Medical College, Tumkur, Karnataka. So I actually attended CCPPM course in Pallium, India, and I also got inspired with Dr. Rajagopal sir's work and his documentary. So with that, I got the interest in this palliative care, and I wanted to pursue it.
Warm welcome, Dr. Bharat. We could see a lot of people just like you getting inspired by Dr. Raj's services to the society. So moving on, Dr. Priyanka Chaurasia.
Ma'am, you are muted. We can't hear you.
Hello.
Yes, ma'am. Now we can hear. Can you go again?
I got exposure to pain and palliative medicine while I was doing PG in my college, and I developed a keen interest in this field, and I've done the foundation course, and I'm looking forward to the second part of this course. Thank you.
Thank you, Dr. Priyanka. I believe we have Dr. Manglik thus joining us. Dr. Manglik? Maybe we lost him because of some connectivity issue. I hope I have called out everyone's name. If anyone, so sorry about that. We have a power failure here. Am I audible, ma'am?
Yes, you are audible.
You are. Okay.
I want to say one thing. I am Dr. Dipankar Dakwa from Guwahati. Our head of the department, Dr. Arun Deka sir, who was unable to join, so he has joined with me. He will give his introduction, please.
Sure.
Hello everyone. Am I audible?
Yes, sir. Perfect.
I am Dr. Arun Deka. I am from Guwahati State Cancer Institute. I am basically from the Department of Anesthesia. I have an experience in palliative care for many years, and I am heading the department now at State Cancer Institute. Is a cancer institute, and I joined here to know more about palliative care. And most importantly, I want to learn from Rajagopal, because I have not got any experience directly from Rajagopal sir. So I thought I will have a first-hand experience with Rajagopal sir. That is the whole idea behind of joining this course. Thank you.
Thank you, Dr. Arun. Anyone else whom I have skipped, whom I believe I have called out everyone's name. If anybody is left, I do humbly request them to come forward and introduce themselves. Otherwise, it is again back to Dr. Sridevi and Dr. Rajagopal.
I think we have heard from everyone. So nice to see from different departments, non-clinical, clinical departments, a lot of radiation oncologists. So it's nice to see this crowd together and for one cause. So without much delay, I would like to tell Dr. Raj to talk to the participants. So,
Thank you, Sri and Sri. Hey, everybody. Hello. You make me very, very happy. we are on a very great mission. I'll explain why I say that. Not empty words. We truly are. It's good to see the spread over numerous specialities and the geographical spread. Of course, there are many friends here whom I have seen only virtually. I do hope the near future brings us an opportunity to meet in person. So thank you, friends, for being here. Dr. Kadambari, I must apologize. I think this is second time you have to sit through me saying the same thing. But I promise to finish in 15 minutes.
No problem, sir. No problem.
So friends, I told you earlier that we are on a noble mission. And let me explain why I say that. Sri, can I share a screen?
Sure, sir. Access is all yours.
During the last 10 years, after more than 35 years of palliative care in this country, or now, but in the last 10 years, many positive things have happened in our country. For one thing, the first was the National Program for Palliative Care, by which the government of India gives funds to any state for palliative care delivery. Many crores are given out. Unfortunately, it is done year by year. That itself limits the opportunities. That is true, but you should know that money is there. That means the government of India has accepted palliative care as one of its programs. We had one major hurdle in access to opioids for pain relief. Partially, that has been changed by Narcotics Amendment Act of 2014. But many of you would not have seen it actually translated into practice in your own state, because this is a problem that we have, because legislation or national policies, usually both in health and opioid access, are under the state control. The government of India can formulate policies and laws, but the states will have to implement them. So there's an implementation gap. Okay. The National Health Policy of 2017 includes palliative care at the primary level. For some strange reason, this is a bit of a strange thing that's happening in our country, that in most states and at the national level, palliative care programs are included for primary care, which is great, wonderful, but it's not there at tertiary centers. Okay, many of you are from tertiary centers which have palliative care, but we must admit that that must be a tiny minority of tertiary care centers. But with this again, some important steps have been taken. Then the government of India, we had the privilege to work with them, and Sridevi and others were fully immersed in doing many things about it for a couple of years. We have created documents, text documents, PowerPoints, and trigger videos separately for ASHA workers, multi-purpose health workers, nurses, and doctors. So these resources are available, and national level trainers were trained first, and then state level trainers were trained. So from every state that you have listed out here, state level trainers have been trained. But as it happens, unfortunately, unless the state government also now takes it forward at this stage, it will not be translated to action. Some of my colleagues you must have met in your own state, in the Northeast, Ron, in the North, Rajendra, and in so many places. Our colleagues are there to work with you to make it happen. And finally, it has got into the curriculum, medical and nursing curriculum. students from the year 2019 have it formally in the curriculum. Pain management, end-of-life care, attitude, ethics, and communication, all this is in the curriculum. But having it in the curriculum is one thing. Making it actually happen is another, which is why we are all here. We are all here to facilitate this process. Every one of you, Divankar, every single person, Pamela, I see some very senior professors here, Pamela, Dr. Sanjeev, Devi, Sweta, everybody. We all have a big role to play. In fact, the more senior people may have less time to give to this. Some of us may have more time. I see several people from community medicine. I'm sure they have a very important role to play because they are actually working with the students and the house surgeons on the ground. That gives us a great opportunity. The problem that I see now is that of the 620 odd medical colleges in the country, which together train about 1 lakh of medical students everywhere. I think the latest was 98 something. Now, they have it in the curriculum, but how will they learn? When in most of them, except for about 40 of the 620 medical colleges, when the majority of them have no palliative care, faculty have had no palliative care training, how on earth are they going to learn? There's another fear. Will they be taught very wrong concepts? Quite possible. Even what is palliative care? Wrong concepts about opioids, wrong concepts about end-of-life care. This is a major concern, which is why I said everyone in this group, the seniors, particularly by influencing institutional policy, and the juniors maybe possibly by more getting actively involved in the training. We have this opportunity of making it happen in our individual institutions. One important point that I want to make. This cannot be confined to your department. If we are taking, when we take on this, not if, when we take on this mission, I do hope that you will be able to spread your wings beyond your individual specialty and individual department. That's okay. The National Medical Commission has made a provision for adjunct faculty. If you are in community medicine, the college can easily make you an adjunct faculty member or in physiology, in pharmacology, anywhere to teach the subject. If they are willing to welcome you and you are willing to go and do it, the sky is the limit. You can do a lot. This is what I hope we'll do. I hope everyone here will be not only teaching palliative care to the students who come to you, but I hope you will be agents of change, making this major change happen in medical education in your own institutions. We will, as the days go by, we will talk more about it. But let me also make one other point. At least 2 members of the group are oncologists. The others come from various other specialties. Now, what is palliative care? I hope we will all accept the responsibility to treat all serious health-related suffering. Not necessarily end of life, not necessarily cancer, not necessarily limited in time. Integrated into healthcare from the beginning to the end. Wherever there is suffering, we will go in and help. This may not be chronic. Somebody may be in agony following a surgery and they seek your help. And I hope we will all teach our students how to be helpful in those environments. But particularly remember, friends, that of the, if we take, this is for low and middle income countries, the red stands for HIV. If we take globally, the one single diagnosis causing most health-related suffering is HIV. That's not so in our country, I admit. But in some states, the burden is tremendous. Cancer comes second. Of course, in this, childhood leukemias are classed separately. So total will come about 22. Globally, about 1/4 of all serious health-related suffering is caused by cancer, and everything is by everything else. So when we teach palliative care and when we practice it, wherever there's an opportunity, I hope we will all be willing to take on patients, not only within our own specialty, but in any part of it. In the last few minutes, I have made two main points. One, that we all need to be agents of change, facilitating palliative care education for undergraduates beyond our specialty, possibly beyond your institution. Even if there's another medical college in the city, I hope you will exert your influence there. The second point is, hopefully, we will not restrict it in the name of a diagnosis. We will never discriminate in the name of caste, creed, or religion, would we? Similarly, we should not discriminate in the name of a diagnosis either. So these are the 2 points I have just now made. Would anyone have any comments about the 2 of them or any question?
Hello, sir. Myself, Dr. Dipankar, sir.
Hi, Dr. Dipankar.
Hello, sir. Sir, I just wanted to know, I have not done any MD courses, sir. I am practicing palliative care since now it is almost 12 years. So I have done my 1-year certificate course from B. Borua Cancer Institute. I know you are familiar with it. And again, I have done ISCA certificate course, which is also affiliated from Piliam, India. 6 weeks certificate course from Tata Memorial Center, Mumbai. So here in our institute, State Cancer Institute, I am teaching all the fellows, MDs, then even the MCH students who are coming about palliative care. What is it? I do classes for them. But even they have not given us the faculty status, sir. It is not possible, I understand that. But if some means if they say us that you can teach in the medical college also, then how can we implement those things here, sir? I just wanted to know it, sir.
Dr. Dipankar, my personal opinion is you are more qualified to practice palliative care than we specialists. I am an anesthetist. That limits my field, limits my vision, whereas you have the broader perspective. So I genuinely feel you are as well equipped as anybody else to practice palliative care. Having said that, the limitation that has been brought in, that to become an assistant professor in a medical college in any field, you would need to have a MD or DNB. That's a national regulation, which I fear that will not be easy to change. It can be changed if Union Health Minister as well as the President of the National Medical Commission says so. This can be waived for a certain number of years. You say that it's grandfathering in. Palliative care is a growing specialty. So for the first 30 years, this is relaxed. This has been done once. When I was a young man, our faculty members were there for who were given exemption, because those were early days for modern medicine in India. Similarly, it is possible, but it's not easy, I can assure you. It will really need interest at the high places. So we have a problem here, and very unfortunately, the procedural restrictions will limit your faculty position unless the National Medical Commission and the or the government of India influencing the National Medical Commission influences other decision. And related to that, I have another point to make. This may be easier to handle. I see that at least 3 of the group are from community medicine. If you ask me, they are more qualified to do and teach palliative medicine than an anesthesiologist or even a pulmonologist, I would say, because that's so much varied. You go out into the field, you know primary care. Unfortunately, in the current qualifications for MD in palliative medicine, community medicine is not included. The reason I am told comes within the purview of community medicine. In the National Medical or the previous Medical Council documents, in the 2 or 3 places, it is included as a non-clinical subject. Very unfortunate. And in one place, it's also mentioned as a clinical subject. So I think I personally would have been very, very pleased for the future of my own health and palliative care needs of tomorrow if you, public health people in community medicine, took the lead to get the National Medical Commission to accept community medicine as a medical specialty. That will be good for us. You will be able to be, those people will be able to become faculty members for teaching palliative medicine also. Okay, so sorry if that answer is a bit discouraging, Dr. Deepankar. Is there any other comment or question?
No, sir, that's all. Thank you. Thank you, sir.
Anybody else? Dr. Kadambari, did you have any comment based on your experience with the last batch also?
Good evening, everybody. Somebody has raised a hand, sir. Dr. Bharatnag. Maybe.
Dr. Bharat?
Good afternoon, sir.
Good afternoon.
Actually, except that, sir, it was mentioned, community medicine was mentioned in preclinical previously. Now, in a new curriculum which they have released for CBME, they have given 3 groups: preclinicals, medical group of subjects, and surgical group of subjects. So, in medical group of subjects, ours is the first subject which has been mentioned, and now NMC has completely approved that we are falling into medical group of subjects. So I think
very good. Congratulations, Dr. Bharat. And I have 2 requests to you. One, can you please send me any document which lists that NMC document, a copy or a link? I will appreciate. Secondly, now you have one more bigger task to do. In the MD palliative medicine curriculum of NMC, and more or less following the same lines with the National Board of Examinations, community medicine is not included in the subjects which qualifies somebody to be a palliative medicine teacher. For palliative medicine, if you have a department of palliative medicine, today the faculty members are from a certain listed number of specialties, not including community medicine. So your national association or individuals, I hope, will give you the NMC curriculum so that you can base it on that. Will approach the National Medical Commission and request that one change in the MD palliative medicine curriculum. And I'll be happy to work with you in drafting that thing. and maybe to talk with you more about it. I have exceeded my time. I promised to be brief, but Dr. Kadambari, were you about to say something?
Just a response to the previous speaker who was saying he's not accepted as a faculty. I have a suggestion. If the medical college in the same city he was mentioning, there is a medical college. I think he's from Assam. So
Yes,
yes, so if you have a medical college in your place and you are a cancer treating institute, since palliative medicine has been included in the curriculum, you can enter into some kind of memorandum of understanding with the medical college, that is possible, where you will be conducting the teaching program in palliative medicine, because you have so many years of experience and you have taught MD and MCH students, and so that experience in your CV will definitely put you, even though you may not get the designation as a faculty, but you can definitely contribute to teaching palliative medicine to undergraduates. That's a possibility.
Thank you, ma'am.
Thank you, ma'am.
Sridevi, I think I have said what I wanted to say, and as I have taken so much of time, shall I hand this back to you? And friends, everybody, thank you for walking with us on this journey.
Thank you. Thank you so much, sir. Thank you. We will move on to the next part of today's session. It's a session on integration, principles of integration in education. Sripriya?
Yes, ma'am. Just a moment. Just a moment, ma'am. I'm facing a little technical glitch.
So, you know that we have been hearing this term integration right and left after the, sorry, just. So we are hearing this term a lot after the CBME, the vertical integration and the horizontal integration. We do talk about a lot, and even we call our program integrating palliative care into undergraduate medical education. So I thought it is very important to understand the concepts of integration a little in depth than just simply using the term integration. So today we have Dr. Kadambari from JIPMA. She's a professor in the Department of Surgery, and she's main interest is in breast oncology and breast surgery, but I must say she's a very good teacher, and she works with the medical education department, and she's one of the resource persons for the NTTC program run by the medical education unit at JIPMA. Sorry for the background noise. Welcome you, ma'am, to this second program on second faculty development program in palliative medicine. Thank you so much for agreeing in the last minute.
Thank you, Dr. Sridevi. It's always a pleasure to be a part of any faculty development program, because there is so much to be done. And we have such enthusiastic teachers all over the country who want to do so much for students, whether they are undergraduates and postgraduates. And in any way that we can help, I'm happy to do so. Okay. So we'll begin. Shall I begin my slides? Can I share the slides?
Yes.
Okay. Right. So what I'm going to focus on is a little bit about the science of learning, which tells us quite a bit about what integration is and how we can implement integration in our day-to-day teaching. So it may be a little theoretical in the beginning, but as we all know, it's also important for us to understand theory before we can actually start implementing what we learn in our daily practice. So a quick definition, it comes from a Latin term which refers to the whole, the entire. And as we know, the whole is more than just the sum of its parts, right? So it is a very, it means something which is complete or which is the entire thing. That is what integration is. And if you look at the life of all of us, we are doctors, and we face a lot of demands on our time as professionals. We have to diagnose, we have to treat, we have to, in addition, we have to stay current on our knowledge and research. And above all, we have to have the service orientation because we are here to help humanity. So if it may not be wrong to say, therefore, that integration is a core aspect of medical practice. So as practitioners, we are integrating several roles or several demands on us as professionals in order to serve the carry out our professional responsibilities. If you take education, before that, as teachers, we are all teachers. As I've seen, many of you are working in medical colleges all over the country, or involved in teaching at some level or the other. So when we talk about integration, there are two main things we need to understand. We need to understand what is integration and how it occurs, which is the theoretical aspect. And the more practical thing is how we can scaffold or how we can develop, help integration to develop in the learner, whether undergraduate or postgraduate. So we'll just to expand on what we saw as integration, would anybody like to come up with an idea of what integration actually means when we talk about in education? You can type in your answers in the chat box. Just what comes to strikes you when you hear the term integration.
Hello. Hello.
Yes.
Yeah. What I feel regarding the word integration means, our idea is to bring all the subjects, related subjects which deal with palliative or related palliative care, all subjects together. It may be surgical oncology, it may be medical oncology, it may be community medicine, it may be a person who is dealing with HIV, it may be a person pure medicine, or every subject should come under one roof. That I think it's integration.
Very nice. So it's basically coming together of, because we have to face it that medicine has split up into so many specialties and is splitting still further into subspecialties. So it's coming together, we could call it a coming together of all these specialties in our practice. You can, one way of looking at integration, what you're talking about is integration in practice. But when you talk about integration in learning, in education, it is basically a knowledge synthesis, right? So if you, that means the student is making connections between all the inputs and experiences that he is going through and developing new knowledge and understanding. Okay, so that is what we mean by integration in education. So that means it is happening in the mind of the learner. So integration is something that is actually happening in the learner, right? And that is what we need to work on. How do we promote this integration to happen in the mind of the learner? Right. So if you see the undergraduate curriculum, as we know, there are so many subjects, so many different types of experiences that are that a student is exposed to. And each subject has its importance, right? So it becomes the burden of the student to make the connections, and with the help of these connections, negotiate on the complex pathway of clinical practice, right? So that is in a nutshell what happens in undergraduate medical education. So therefore, if you talk about integration in UG medical education, there are several experiences: basic science, clinical, there is factual knowledge, there is experiential learning in the, you can call it by the bedside, or in the outpatient, in the operating theater, in the community. There are so many settings where experiences are collected. Now the student has to put together all these experiences, connect them, and develop an understanding so that he is able to perform the professional activities of medicine. That is what is the core meaning of integration. So therefore, integration can be seen as three things. One is it can be seen as an educational outcome, which is what we commonly refer to when we talk about integration. So that is integration of learning. It can be seen as a learning process. During the learning, how integration is happening, that is integration of knowledge and integration of memory. And finally, how can we as teachers or as the educational system implement practices to achieve this desired educational outcome? So that is curriculum integration. And what the MCI prescribes in its curriculum is the curriculum integration. It tells you, you can do this, you can do that, you can arrange the curriculum this way, you can do that, bring in subjects, bring in linkers, connecting cases. Those are all curricular arrangements. Okay, so we'll look at these three aspects one by one. Now, if you look at it as an educational outcome, it's a very, very important thing, as we saw, that integration of learning has to happen, because we want students to develop a higher order learning. We want students to move from a basic understanding to more abstract conceptualization, or more complex understanding, building on knowledge of isolated facts, and develop ideas in new and different ways. If we take research, for example, we have facts, we know certain things, but because we are trying to connect different facts, different observations that we make, we come up with an idea for a research, for example, right? So that is, it's a process which happens to us as part of our normal thinking. We are all the time trying to make these connections. That is a normal human mind, always tries to make these connections. So therefore, integration of learning or integration of as a learning outcome is a very important aspect of integration. Because meaningful knowledge learning is said to occur only when they make these connections, and building a domain of knowledge in any, it can be, let's take medicine here, because we're talking about medicine, medical students, without the ability to integrate information learned in different times and in different places, building a domain of knowledge in medicine would not be possible. So it's a very basic aspect of learning in any professional subject, and be it medicine, nursing, dentistry, whatever. The second aspect of integration is to look at it as a learning process. So knowledge integration, which is what is happening in the learner, he is integrating the knowledge. So this refers to the mental process through which the learners are putting together all these different experiences and trying to connect them. So, for example, in undergraduate medical education, making connections within subjects and between subjects is a type of knowledge integration. Making connections between anatomy and physiology, making connections between different systems in anatomy, making connections between anatomy and surgery. All these are examples of knowledge integration. Now, as I mentioned, integration is not something that is seen only in adult education. It happens naturally in childhood learning itself. as young as 4 to 6 years, children are able to make connections between facts which are gained and at different times. And as the speed of grasping knowledge increases, between 4 and 6 years itself, children become independent, relatively more independent, and are able to make those connections and are not necessarily dependent upon the teacher. So what I'm trying to drive here is integration is a natural process of learning that we all experience, or all of us practice, maybe even subconsciously. So now for this kind of mental process of making connections to happen, or this knowledge integration to happen, we need to have a knowledge base, right? We need to have facts, we need to have knowledge at hand in order for us to make those connections. And in order to build such a knowledge base, we need to have we need to practice what is known as memory integration. So just a quick look at how learning actually occurs. If you have an individual, let's take this as a student, there are so many experiences, or even ourselves as normal human beings, we are facing so many experiences in life. Now, all these experiences are coded in the human brain in various areas. And this process, as I said, is called encoding. And this process of encoding is stabilized. Okay, these are called representations in the brain. And these representations or encoded information is stabilized during sleep, which occurs naturally by a process which is known as consolidation. So sleep is very essential for building memory, right? So this process of encoding, forming representations, and consolidation is referred to as storage. Okay. Now, to develop the memory further, we need to go through a process of what is known as retrieval, and which is what happens when we are faced with examinations or tests. So these two steps of storage and retrieval are both very essential for developing knowledge or learning, right? So this is what I'm trying to drive at. So as teachers, we are responsible for both the storage aspect and as well as for the retrieval aspect. So coming back to memory integration. So memory integration, as we know, is necessary for developing the knowledge base, which is necessary for developing integration of knowledge. So how does memory integration help? It by reactivating prior knowledge during learning of new information that results in stronger association of new information with existing knowledge networks. So this is a study strategy. So if a student, for example, is studying surgery or medicine, and while he is studying the clinical findings or looking at the clinical presentation of a particular illness, he consciously reactivates prior knowledge of anatomy or physiology. It develops into a stronger association of the knowledge network. He understands better. So this can be seen how memory integration is employed as a study strategy. The second concept is that memory will be stronger when information already has a pre-existing association, so that reactivated memory is congruent with newly learned information. Now, this could be taken as a teaching strategy. So I am a surgeon, and when I take classes, for example, on breast cancer, if in my class, I'm able to reactivate their memory of pathology, of anatomy, of physiology, of embryology, then that becomes, they are able to make the connections with what I am talking about in breast cancer. So that is a teaching strategy, right? And finally, you have the third component of teaching learning, that is assessment, when we actively reactivate previously learned information And that is for beneficial for subsequent memory. So memory integration can be employed as a study strategy, as a teaching strategy, as well as an assessment strategy. So as teachers, what are the questions that we are asking? First of all, why is integration needed? Second, what are the elements to be integrated? Means what are the different curricular components that need to be integrated? When should this integration occur? Where should it occur? And how can we scaffold it, or how can we promote the integration? I'll just pause here. Dr. Sridevi, do we divide them into groups?
Sorry, ma'am, can you? Yeah, there was a distance. Can you ask me again?
Do we have you divided them into groups for a group discussion, or shall I just proceed by like
if
last
you
time?
want them to be in small groups, not the assigned groups, but we can divide them into small breakout rooms if we have. How much time do you need?
Okay, I have not actually planned for a breakout session.
Then
so
we
maybe
can go ahead with the interactive questions.
Like last time on the chat
Sure,
box.
sure.
Okay, fine. So we'll look at these questions one by one. A quick question, why do you think integration is needed? We have looked at integration of learning here as an educational outcome. Why do you think integration is needed? Anybody would like to volunteer a response in the chat box? Why do you think it's needed? Somebody has written. For wholesome knowledge and better understanding and learning. Yes. For better understanding of the topic. Okay. Yes. So actually we have more or less discussed this because we have already seen how important integration is in as a core aspect of medical practice. So the commonest what shall I say, the commonest aspect of integration that is addressed mostly is the integrating basic and clinical science education in undergraduate medical curriculum. So this is needed. Do you think this is needed on integrating basic and clinical sciences, and what for? I just gave you an example of my own class where I try to recall pathology and anatomy. Yes, somebody has raised a hand, I think.
Yes, yeah, it is needed because, for example, a person who is in basic sciences is learning about the liver function tests and raised bilirubin and all. And if they can see a patient in the ward with jaundice, their understanding of the topic and the retainment, their memory retainment will be much better. So it is definitely needed. Otherwise, during our times, by the time we finish the basic sciences and go to the clinical side, we have forgotten most of what we learned in biochemistry and physiology.
Yes, right. So basically, their knowledge in the basic sciences is required for understanding clinical signs and symptoms. If you look at it from the other way, why do they need basic science knowledge? Because they need to relate clinical features to mechanisms of disease, which is what they study in the basic sciences. They need it for diagnostic reasoning. Why basic science is needed? Because they need it for making the differential diagnosis and also to solve difficult diagnostic problems, right? Now, a quick question to you, just type in yes or no. Do clinicians routinely use their knowledge of basic sciences to make a diagnosis? Just say yes or no. Yes, yes, yes. Okay. Yes. Okay. All right. Thank you. So the catch of this question is the word routinely, right? Many of us are clinicians, right? Do we routinely recall our basic science knowledge when we are making a clinical diagnosis? So the answer is conditional. It depends upon the level of learning. If you take a novice learner, they would need their knowledge of basic sciences, and they use what is known as analytical reasoning to make a diagnosis. So they consciously make these connections and they say, okay, this is where I'm auscultating, and this is or palpating the liver, and this is how I have to focus on the right hypochondrium, and that kind of a thing. So they consciously connect between their knowledge of basic and clinical sciences to make a diagnosis. But if you take experts, experienced or experts in a subject, they resort to what is known as non-analytical reasoning, because they have already done something called encapsulation. Their basic science knowledge is already deeply ingrained in their memory. And with experience in clinical practice, they develop what are known as illness scripts. So when they see a case, they automatically, subconsciously make connections with previously seen similar cases. So the exception is only when they are faced with a difficult or an uncertain situation. Okay, so that is about why we need integration, right? So some of the other reasons which are listed are dealing with complex problems, fostering higher order thinking, and getting to know what are real world problems. And it makes learning very interesting, right? It gives them the relevance. Why am I studying microbiology? Why do I need to know so much about so many organisms, whether they are gram-positive, gram-negative, blah, blah, blah. So if you make the connections, if they're able to make connections, it becomes more exciting for them to learn. And reinforcement of important topics. Okay. Now we go on to the next question. What should be integrated and when? And this is where I would like to ask all of you, because we are talking about integrating palliative care in undergraduate medical education. So what do you think should be integrated? When we talk about integration in undergraduate education, what all do you think should be integrated apart from integrating basic and clinical sciences? Right from first professional year. Okay, that is the answer to the second part of the question, when. Okay. Okay, so in interest of time, I will answer the question myself. So what we are talking about here is integrating not only content knowledge, but also skills. And here we are talking about attitudes, right? So it's a comprehensive learning that happens. We need to make students aware, bring to their awareness this required attitude towards their profession. Now we can do it in many ways. Okay, we can have we'll come to that a little later, but basically what we need to integrate is all the three components of learning, that is knowledge, skills, and attitudes. So as you rightly pointed it out, it has to happen right from the first year, from the first semester, between the subjects in the first year, and across the years, right? So both horizontal and vertical integration should be happening. So that is about when. And this is needed because there are a number of domains that a student is exposed to. Basic science, clinical sciences, and they have to, as I said, they're all their experiences, they have to put together what are all the different types of cases they are exposed to, different experiences in community, outpatient, etc. And also this self-knowledge, that is the attitude. They have to have the habit of introspecting and reflecting on their own behavior, their own attitudes, in order to develop the right kind of approach to a patient in their regular practice, and also how to work in a team. So all these domains have to be integrated in the MBBS learning. So where can it be implemented? Everywhere where learning occurs, right? In the classroom, in a simulation center, in the clinic or the bedside, in the community, and in interprofessional learning environments. Okay. Any questions until now, or any comments or questions, or we'll move on to the next most important one. How do we actually promote integration? Any quick
Ma'am,
questions?
actually, I want to know.
Yes.
Someone told a few minutes ago the vertical integration and horizontal integration. What is that two terms?
Okay. So this is horizontal integration is across a year. So for example, integrating anatomy, physiology, and biochemistry in first year. Okay. Integrating pathology, microbiology, forensic in the second year. And integrating the clinical disciplines in the clinical curriculum. That is the horizontal integration. Vertical integration is across the years, integrating anatomy with surgery, integrating anatomy with pathology, integrating physiology and pharmacology, and so on. That is example of vertical integration. Is it clear?
Yes, ma'am, very much. So one is intra, the other one is inter. Can you say like that also?
Yes, yes.
Okay. Okay, ma'am.
Right. So we'll move on to the most important question which we face as teachers. Now, how can we promote this integration, right? So basically, when there are what we call, these would be called labeled as educational strategies, and both the learner and the teacher has a role to play. The learner has to develop effective learning strategies, and the teacher has to develop effective teaching and curricular strategies. So as we all agreed, actually integration is happening in the mind of the learner. So the learner has an equal responsibility for making those connections during his learning. So these effective learning, there are many effective learning techniques which have been described in literature, which is otherwise known as the science of learning. And for those of you who are curious, you can look up a book called Make It Stick. And it's a very nicely written book. Or if you just Google effective learning techniques or science of learning, you will see a lot of freely available literature which talks about these learning strategies. So I am not going into those techniques. So primarily they are directed towards creation of a strong knowledge base, how the student is able to create that knowledge base. Now, before we move on, all of you, most of you are teachers in medical colleges. So what have you done as a teacher to support integration? Any strategies you have implemented as teachers? Because there is no right or wrong strategy. We all as teachers have our own way of doing things. Anybody would like to share? You can unmute yourself. I think Dr. Pamela is trying to type something.
No, I do have experience because I am also part of the medical education unit here. So a lot of integration we practice, especially we used to have it even before, about 20 years back also, but not in an organized and systematic way where we have it properly. So we do under the NMC curriculum, the timetable, all integrations, both vertical and horizontal integrations. They practice.
Okay. Okay. Right. So I'm going to differ a little bit from what is prescribed by the NMC, because that is more of a curriculum strategy. Okay, horizontal and vertical integration is a curricular strategy. But as teachers, we may be implementing many ways of trying to help students to make those connections, which are vital to their understanding of a subject. So there are teaching strategies which are described. Go into the depth of the curriculum, going into a depth which we judge as teachers, okay, this depth is sufficient for an undergraduate to understand a particular topic. Give them enough time, adequate time for a topic so that they are able to make those connections. Introduce what are known as desirable difficulties. I have listed some here, but I'm not going to go into the depth. Again, I would request you to, because that is really not the scope of this talk. But these are basically difficulties. Don't provide them with all the information. Okay, in simple terms, it is that. So don't make a lecture a complete thesis of a particular topic. Give them the important concepts that they need to grasp in order to understand. And give them an assignment, for example, and ask them to go back and develop their understanding in a greater depth by reading up on their own. Okay, so that is one of the examples of desirable difficulties. The other example which is here is practice testing. And all of you might have heard of the term formative assessment. So one of the ways of implementing formative assessment is this practice testing. So if you have 3 classes in a row, you take a class today and you have a class again next week. In your next class, start off the class by asking a few questions on your previous class. Okay, so they are forced to recollect and retrieve. That process of retrieval you are triggering and helping them to make that connection, right? So that is practice testing. These are teaching strategies. You design your assessments to promote integration. Ask questions in such a way that you see whether they are able to make those connections. You train your learners in effective learning techniques. Familiarize yourself with what are the learning techniques which are required for a student to develop a knowledge base. And finally, the curricular arrangements, all these horizontal, vertical, and other things. So when you're teaching, as you teach a topic, continuously make those connections amongst concepts, principles, whether it's in a lecture or a lab. Connect the experience which they have in a lecture with the experience that they have in a lab. Okay. And among major sections, as I said, in a clinical discipline, we have the most important responsibility of helping them make those connections. And this is what I said about desirable difficulties. And many times we don't know what are the assessment strategies that will test integration. I've just given a small example. As teachers, we have the freedom to do what we feel is best for the student. So there is no prescription that this is the way you have to design your assessment. Primarily, you have to force them to make the connections. So you ask a question which will expect them to demonstrate that they have made the connection. For example, you ask an MCQ item. You can follow up the MCQ item with a question asking them to explain why they have made that choice in the MCQ, right? So that way they can demonstrate, okay, this is the pathophysiology, this is the reason why I'm choosing this drug, this is how its mechanism of action, etc. Right? So that is one way you can do. This is just an example. There are myriad ways of doing it, and it's up to you to find a way. So basically, assessment practice has the retrieval practice effect, or this is known as the testing effect, using tests to for memory integration. So memory retrieval depends primarily on the cues, right? The cues are the questions that you ask. So it all depends on how well you frame your questions, how well you ask them the critical question, which requires them to make those connections. So if you ask them a simple question, which just asks them to recall from their memory, for example, that doesn't tell you whether they have made the connection. But you ask them a question which requires them to show that they have made those connections, then that would be a better way of. So basically, it all depends upon the cue. The cue is the question that you are asking. Finally, coming to the curriculum arrangements, right? There are many models which have been described. There is this H to Z model. There is the spiral curriculum. There is this horizontal and vertical integration. Any number of ways of. And finally, Dr. Pamela may be already familiar with this. This is known as the integration ladder, which was described by a very famous educationalist known as called Dr. Harden. And it's a very complicated thing. Basically, he's talking about ways in which the boundaries between disciplines are broken and become fuzzy. So there is no anatomy, physiology, biochemistry, etc. There is just concepts like it could be pain, for example. Pain can be one core topic. And then you bring in all the disciplines which are responsible for the physiologists, the pathologists, the palliative care, medicine, etc., anesthesia, whatever, all those disciplines. So there is no disciplinary arrangement of the curriculum. It becomes what is known as inter or transdisciplinary. Not a very easy thing to do. It's very challenging. And in my opinion, it's not always necessary for us to break those disciplinary boundaries. It is very difficult and sometimes not even practical. So even in the lower levels of the integration ladder, we can still promote integration in our students, right? So this is an integrated curriculum, as I mentioned. All the subject matter lines are broken and you focus on broad areas of study. So this is an example of an integrated curriculum. As you can see, there are topics like homeostasis, transition to patient care, principal clinical experience, and all. This is a very modern curriculum which is implemented in Harvard Medical School. And there is no anatomy, 6 months in anatomy, 1 year in pathology and things like that, the way we do. But as I said, curriculum arrangements are not sufficient by themselves to promote integration of learning, right? So what we need is a curriculum where knowledge is slowly expanded and we give enough time for previously learned information to be revisited for allowing the knowledge networks to form. Now, it's very easy to speak about all these things, but there are many challenges, which is what another aspect that we need to discuss today, because integrating palliative care is a big challenge, as you will see. So some of the challenges would you like to share your experiences? Would anybody like to say what challenges we will face when we implement integration?
Especially with palliative, ma'am, other subjects, subject like medicine, surgery, or any other subject. So they don't consider palliative care is a very good subject to be integrated. They consider it to be some. I may be wrong. This is my feeling. They consider it somewhere it's end of life care. Their assumption is like that. Their end of life care. What to integrate? Okay, anyway, patient is going to die. Let them do their own. Like some hesitancy is there somewhere in other subject. I feel like that, ma'am.
Okay. Anybody else?
There are a few chats also.
Oh, okay. I missed that. Lack of awareness, yes. Non-coordination, very good. Unavailability of faculty, time crunch. Availability of faculty, anatomy teacher, inviting subject experts. Okay, that is probably one of the strategies. Okay, lack of awareness, lack of time and communication. Yes, I think you've hit the nail on the head, Dr. Anju. Lack of communication. Yeah, that is probably the biggest challenge that we face when we are talking about integration, right? Because somebody mentioned that we call, for example, if you're an anatomy teacher and you're talking about the inguinal region, right? You call a surgeon to come and talk about inguinal hernia or surgery for inguinal hernia, or what is the applied anatomy. I say it's not necessary, right? What you need is the anatomist and the surgeon to get together, talk to each other, maybe over a cup of tea or over a chat. Just talk to each other. Let the anatomist understand from the surgeon what the surgeon expects from an undergraduate student to understand about inguinal anatomy and inguinal hernia. That way, the anatomy class can be made more interesting by the anatomist herself or himself, because they are all, after all, they've all been through the MBBS course, right? So they're already familiar with some of the all the clinical subjects. So all we need to do is sit and talk to each other. If an anatomist wants a radiologist to show some cross-sectional CTs or something in their class, talk to the radiologist. Ask them to show some typical radiological images, help them to interpret. They can, because getting a radiologist, getting a surgeon to your class is a nightmare. Okay, it's very difficult to coordinate with others. And what I'm saying is it's not always necessary, not always. When you can do it, but it's difficult to organize on a regular basis. Okay. So the first and foremost challenge is the lack of will, right? Something that Dr. Arun also mentioned, there is a lack of will. There is a lack of good leadership support. Probably that's not so important now. We are having a lot of support from our deans because there is a pressure from the NMC to implement integration. Inadequate infrastructure, right? We have only 2 radiologists in our institute. They cannot keep coming for all the anatomy classes. So it's difficult. Prefixed mindset. This is the biggest challenge, right? I am taking a class in surgery. I will speak only on surgery. I don't need to speak about the anatomy because he has already studied anatomy in the first year. That is a prefixed mindset. Faculty resistance due to fear of more work. And there are some myths that multiple teachers will be required for an integrated session. I already mentioned it earlier. Integrated curriculum will cause more confusion. I don't see how that can happen. Department will lose its identity, right? I'm afraid if the anatomist is already talking about inguinal hernia, then what am I going to teach when they come to surgery, right? So my identity as a surgery teacher will be lost. Okay, so these are some of the so-called challenges that we are facing, and none of them are insurmountable. Definitely all we need to do is sit and talk to each other. Right. There may be a lot of other challenges which are contextual, which are depending on your context and the kind of environment you're working in. So my list is not exhaustive. Right. So in the MBBS curriculum, what we need to do is train teachers, and we need to change that, break that mindset that integration requires multiple teachers. It requires a different way of handling the class. No, it doesn't. It requires just a little bit of tweaking and trying to adjust your content to incorporate all these, the ideas that we talked about just now. Assign responsibilities. Who does what? Develop integrated modules or sessions. Design integrated assessment. So you can teach in any number of ways. You can teach them the inguinal hernia, you can teach them the inguinal canal anatomy and the shutter mechanism, blah, blah, blah. But if you don't ask them that question in their assessment, they're not going to pay any attention to what they have done, and it won't stick in their mind. So you have to design integrated assessment. At least some of the questions should be directed towards integration. And finally, the delivery of the curriculum. So my take-home messages are that integration occurs in the mind of the learner. It's the desired outcome of education. It's an automatic process which begins in childhood learning. Knowledge base is central to integration of learning, and memory integration is in turn required for building a knowledge base. Teaching requires curricular depth, instruction time, and introducing desirable difficulties. Assessments employ retrieval practice and therefore scaffold integration. Curriculum arrangements by themselves do not result in integration of learning. And thank you very much for your patient listening. I'm happy to take any questions. Do we have time, Dr. Sridevi?
Yes, ma'am, we can take a few questions quickly. You can either unmute or type. Yes,
I just wanted to ask, it was an excellent talk and it was very, very informative. I just wanted to ask, when we are talking about scaffolding of integration, you did explain. I just wanted to get it clearer in my mind. It's like how you go about it, right? That's what is under scaffolding of.
Yes. How do you help them to develop? A scaffold is basically built when you are constructing, right? To support the construction. So it's like that. It's derived from that term.
Thank you.
Hello, ma'am.
Yes, Dr.
Actually, I am working in a cancer hospital attached to a medical college. I am invited to take a lecture on 19th, coming 19th. So probably the student will be 3rd year or 4th year. So my topic is end of life care. So how will I integrate my palliative care, end of life care to their subject, like anatomy, physiology? Am I? Ma'am.
Yes. See, end of life care is essentially one aspect of clinical practice.
Yes, ma'am. Very true.
Okay. And when you talk about pain relief, maybe the neuroanatomy is important, right?
Yes.
They need to have a knowledge of the pain pathway and all
Yes,
that kind of a thing. So you can tell them how the different drugs that you use for pain relief or end of life care act, what physiological mechanisms it acts upon, what it affects, what effects it has on different physiological mechanisms. And the pharmacological aspect is generally how the body deals with it, what are the side effects that they need to be aware of, and how to deal with those side effects. Because basically, lecture is just one of the ways in which we create an opportunity for integration, right? There are many experiences which are required. So you can add to your lecture by taking them to your center where you do a palliative care, where you actually implement palliative care. You have patients. If it's a first year set of students, let them simply talk to the patients.
Okay.
Just talking to them gives them that the social burden of end of life situation, having a terminally ill patient, the burden on the family, the burden on the primary caregiver, all those kind of things will open up their mind to something. Okay, there is something called end of life care, which is also important for me to know as a clinician. He need he need not be practicing palliative care, but he knows there is something called palliative care, and there are people who are able to deliver palliative care. So I can send, if I meet a patient like this, so I can send them to so and so, then they will have some benefit from that. Isn't it?
Yes, ma'am. Very
Does
true.
that answer your question? Yeah.
Yes, very right. Yes.
Thank you.
And one more response to Dr. Arun. We'll be sharing the learning materials in the IECO platform, on which the fifth session materials, it is purely on end of life care. So you will get the lesson plan and all the learning materials and activities that you can use for your upcoming session. Like
very nice, ma'am. Very nice. I'll be very happy.
Dr. Pamela has asked a question. End of life care can also come as a part of ethics in AdCom. Can it be called integration? Yes. Any learning experience which helps them to make those connections is integration. And what I see, AdCom is one of the ways. You have a module on ethics. It's one of the ways, but it is not the only way of integrating attitudes. So one is you have a center where you are treating palliative care patients, and you have dedicated people who are, actually giving time for these patients. Take the students to such a facility. That is another experience. When you are talking to them as a clinician, when you're taking a class, for example, a theory class, and again, my own example as a surgeon, I can also give them a case scenario where there is a terminally ill patient. For example, in breast cancer, you have a patient with metastatic breast cancer, cerebral metastasis, bone metastasis. There's very little we can offer for them other than pain relief. So what we need to do is we need to demonstrate our own sensitivity to that subject as a clinician, like what Dr. Arun was pointing out, which is a very sad thing, that surgeons and physicians in general don't believe that palliative care is an important aspect of patient management, which is a wrong thing that we have to, that's a wrong message we send out to our students. So every clinician should integrate palliative care in their own topic. When I'm having a bedside discussion, I should also show them end of life or a patient who has an advanced malignancy and discuss possibilities of relieving his suffering, right? So all of us are involved in integration. That's what I'm trying to say. It's not necessary you have to have an MD in palliative care in order to teach palliative care. I may not know the actual components or what are the steps or, you know, those actual things which are actually done, but I should help them to develop the right attitude towards that situation.
Thank you so much, ma'am.
Okay.
I can't see any other questions, but if you have any questions, please don't hesitate to write to us. Write to us in the WhatsApp.
Ma'am, I think,
yes.
Hello.
Yes,
I
sir.
think, as ma'am said, rather having a MD degree or DM degree, whatever, we should have a mindset to do something good for the needy people. That is what I think the most important qualification, that we should have mindset to help the poor, help the needy people. That is, I think, should be the qualification. Though.
Yes, but you need a workforce also. So that's
Yes,
where probably your MD palliative medicine will come. And one important point, one last point, Dr. Sridevi, bear with me. One very important point which Dr. Rajagopal pointed out is that very few medical colleges have centers for palliative care. So one important thing that students grasp is from us as role models, and secondly, from the institute where they are trained. So you need to have an environment of empathy, right? The institute should be working for the underprivileged, should be working for those who are having this, you know, end of life or advanced malignancies and those kind of situations. So if they are trained in such a situation, automatically, you know, gets embedded in their mind that palliative care is an important aspect of our duty as physicians and surgeons. Thank you.
Very, very important point, ma'am, you pointed out, like they should learn from role modeling, not just from individuals, but also from the institution. Otherwise, they don't understand why it is being taught. There is, that's a huge gap that we face. Very few medical colleges have actual palliative care in practice. Thank you so much, all the participants, for the interaction and asking those important questions, which none of us may not be able to explain. That's why we have medical education experts talking to us. Thank you so much, ma'am, for one more day of sharing your knowledge with all of us. Thank you so much.
Thank you. It's a pleasure. Thank you.
And please, all the participants, please feel free to write to us if you have more questions for Dr. Kadambari. We will convey it to her. Tomorrow we'll be touching a little bit upon HCOM and how to various teaching methodologies to teach serious health-related suffering. We are taking one topic, which is one of the most difficult topic to teach, the serious health-related suffering. So we'll hear from another expert tomorrow. And we have uploaded a lot of learning materials. There is the HCOM booklet. Many of you have already gone through it in your practice otherwise, but those who have not seen or not gone through it, please use those learning materials. And I have provided a document where the palliative care topics are divided under which department it comes. We have shared that also in the IECO platform. So please feel free to open those documents before tomorrow's session. Thank you so much, everyone. Sri Priya.
Thank you, ma'am. Thank you, Dr. Kadambari, for joining us, and thank you all the participants. So with a positive note that we will join again tomorrow for a wonderful discussion. This is Sripriya along with Dr. Kadambari and Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you tomorrow. Till then, everyone, take care. Bye-bye.
Thank you.